Dear Presidents, dear all, I would like to thank you especially for being here against all odds this rainy Sunday morning. I would also like to thank the organizing committee and especially Professor Diamandis for the honorizing invitation. And I would like to thank Professor Nader for her outstanding talk and providing us the theoretical background to proceed and discussing with you drug-induced male infertility and the abnormalities that the drugs may have on this. I would like, in this point, to try to convince you that the contribution of a man in infertility is also a serious business. So, there is definitely a problem. People are getting older, and the older they get, the more medications they take. And use of medications has increased worldwide. On the other hand, men are fathering children later in life than previously. So it was a normal consequence that in 2011, the FDA began requiring evaluation of male reproductive toxicity as a part of pre-marketing studies. So, how can a drug affect male fertility? First of all, male fertility is not only gametogenesis, it's sexual function as well. So, by causing sexual dysfunction like erectile or ejaculatory dysfunction, they impair fertility. On the other hand, we all suspect that by affecting spermatogenesis, fertility may be compromised. And this can be done in all levels of the HPG axis, like disruption of the HPG axis, interference with spermatogenesis, and disruption of epididymal function and sperm maturation. Associating a drug with fertility outcomes can sometimes be challenging because most studies are performed on small samples, so they lack adequate power. Next, there is a lack of randomization, placebo control, or blinding. You can imagine that it's difficult to convince a couple not to use a therapy in order to get children. And there are many confounding factors. The illness drugs treat can have profound effects on fertility. Moreover, we have to also consider the sexual health and fertility of the female partner to assess fertility. There are inter-individual fluctuations in sperm parameters. And unfortunately, these parameters that we assess with semen analysis do not always reflect the fertilizing capacity of the spermatozoa. I will try to discuss the effects of drugs with the level of evidence we have for this. And it's true and really palatable in endocrinological means that androgens really affect male fertility. Actually, they're used as male hormonal contraception. And the most robust data that we have on this issue is by such studies. So we see almost 6 studies backed up by the WHO that they all show that androgen administration may lead to severe oligospermia or azoospermia in more than 80% of men. These effects are hopefully reversible within 3 to 12 months after discontinuing the drug. And this time of recovery depends on the age, the testosterone dose, the route of administration, and the duration of treatment. The same conclusions may be drawn by the abuse of androgens with anabolic androgen steroids, and by the negative feedback that they exert on the HPG axis. Here we can see a very nice meta-analysis done by the group of Professor Tigas, and they all saw that during the anabolic steroid abuse, the FSH and LH were suppressed. The same results were drawn by Professor Nisleg, who shown that current anabolic abusers had very low sperm counts. These low sperm counts persisted until 14 weeks after discontinuation of abuse, and there was a gradual recovery after 14 weeks of abuse. Going the way back, we all can suspect the negative effects that anti-androgens can have on male fertility. An anti-androgen that is widely used in andrology is cyproterone acetate, which is used as a palliative treatment for prostate cancer. It is associated with loss of erectile function and libido. It also decreases all sperm parameters, and these effects are reversible within 6 to 22 weeks. Of course, in this setting, as a palliative, as a therapy for prostate cancer, GnRH agonists and antagonists are used. They act exactly the same way as they do in the female, and by desensitization or blockage, respectively, of the pituitary receptors, they cause chemical castration of the patient. A relevant class of drugs are 5A reductase inhibitors, which are used to treat benign prostate problems, as well as male pattern baldness, but in lower doses. Their action is to block the conversion of testosterone to its active metabolite, dihydrotestosterone, so they lower the levels of DHT by 90% almost, but they let testosterone levels stable or even slightly increased. So they have well-known negative effects on libido and erectile function, and there is a special syndrome called post-finasteride syndrome, where these symptoms persist several months after the discontinuation of the drugs, and even with a normal hormone profile of the treated men. They also cause a significant decrease of sperm count and mobility. However, these changes are not sufficient enough to reduce fertility in men with normal semen prior to therapy. These effects are also reversible 3 to 4 months post-therapy. Regarding the lower doses used for male pattern baldness, we don't have any evidence that they compromise gonadotropin levels or semen quality. Another major class of drugs that is implicated in infertility are psychotropics. These are antidepressants, antipsychotics, recreational drugs, and they almost all of them have negative effects on sexual function and most of them on semen quality. Depression is the 5th most common chronic condition in modern societies, and in the USA, almost 6% of men of, let's say, reproductive age use such medications. Their main effect is an ejaculatory dysfunction, but they also may decrease libido and erectile function. However, we should keep in mind that depression itself may cause ejaculatory dysfunction in untreated men. We all know these major classes of antidepressant drugs. Monoacid inhibitors are the older classes, are tricyclic antidepressants. They were substituted by selective serotonin and reuptake inhibitors, and nowadays with non-SSRIs, which are more modern drugs. SSRIs are the most studied antidepressants with respect to male fertility. They are shown to increase ejaculatory latency in almost 65% of patients, and in 6% of them, they can also lead to retrograde ejaculation. So they can be used as a treatment for premature ejaculation. They have been also shown to have a negative effect on sperm quality and especially on DFI, and this effect is seen quite early, 4 weeks after the introduction of the drug, which means that it may be attributed mainly to abnormal epididymal transit and not to damage of spermatogenesis per se. Long-term use of these drugs has been associated with more dismal effects, and there is insufficient drug data to recommend to our patients to have treatment breaks or to reduce the dose if their mental condition is not well controlled. On the other hand, we have the non-SSRI alternatives, which show minimal effects on PRL secretion or sexual side effects, so they can be used reasonably as alternatives to the SSRI antidepressants. Regarding the older classes of antidepressants, data are quite few because they are not used so often nowadays. We know that they have severe side effects, sexual and not sexual, and they have a moderate effect on PRL secretion. An exception is clomipramine, which profoundly increases PRL and may depress semen quality. Regarding antipsychotics, the landscape is almost the same as in the female patient. We have typical drugs that mostly affect the PRL secretion, and on the other hand, atypical antipsychotics that don't have such a strong ligand with dopamine receptors. However, risperidone and amilsulprid, although they are atypical, they are associated with frequent PRL elevation. PRL is elevated on almost 70% of patients treated with atypical antipsychotics. The rises of PRL are shown immediately upon treatment and generally return to normal within 4 weeks after discontinuation. And in a meta-analysis evaluating the ability of such drugs to cause PRL elevation, showed that risperidone was on the highest range, while aripiprazole was on the lowest. So aripiprazole or clozapine may be also a reasonable alternative to make switching in therapies instead of taking the risk of discontinuing. What about recreational drugs? We all heard before that they have dismal effects in both genders, and that's true also for the male patient. Opioids can affect the HPG axis in almost every level, and they cause a specific type of hypogonadism, which is called opioid-induced androgen deficiency. This type of deficiency, we have most of data from opioids used for analgesic purposes, and it happens in almost 90% of patients. It persists more than 6 months after discontinuation, and less damage can be anticipated by lower doses, short-acting opioids, opioids with mixed receptor activity like tramadol, and transdermal administration in contrast to oral administration. So tramadol may be a nice switch, or we can back up the HBG axis by administrating SERMs to the men who are desiring fertility. What about cannabis? It is quite popular. Endocannabinoids and their receptors make loops in almost every level of the HBG axis and on spermatozoa surface themselves. As yet, the findings regarding the hormonal milieu are inconclusive. However, a decrease in sperm concentration in both humans and animals has been documented after regular exposure to cannabis. There is also association with morphological abnormalities of the spermatozoa and effects on their fertilizing ability which cannot be assessed by direct semen analysis. Another major class of drugs that is also anticipated to cause problems with reproductive axis are glucocorticoids. Acute administration of corticoids in healthy men has been shown to disrupt the reproductive hormone levels transiently. This has also been documented in long-term therapy in patients with chronic inflammatory diseases or solid organ transplantation, and their testosterone levels were lower than in untreated controls. However, one should keep in mind that glucocorticoids were earlier used as empirical treatment of male infertility when antisperm antibodies were detected. The results of such trials were mixed, showing in some cases improvement of semen quality and fertility. However, nowadays it has been abandoned because it is considered that health risks outweigh the benefits of this strategy. So, what if we have problems with corticoids? Then we may use some steroid-sparing agents. Such agents are purine metabolism disruptors. Of these, methotrexate has been associated from animal models with the gonadotoxicity and mainly teratogenic action. The evidence in vivo in men is not, it's limited, and it's drawn from studies when methotrexate was taken concomitantly with other medications. However, it is prudent to stop methotrexate and switch to another steroid-sparing agent, such as azathioprine or mercaptopurine, which do not show significant changes in semen quality or congenital anomalies in the offspring. Other immunosuppressants for more serious conditions are alkylating agents. We all saw how catastrophic they are in female. They are also in the male partner. And cyclophosphamide is the one that has been most studied. It may cause permanent infertility in almost 90% of patients taking high doses. So cryopreservation is the most prudent option in such patients before the administration of cyclophosphamide. Other immunomodulators, such as cyclosporin, TNF inhibitors, or pegydeferin, we don't have solid evidence that they cause infertility problems. And there are some, let's say, lonely anti-inflammatories, such as sulfasalazine, which is used in inflammatory bowel disease, which itself is gonadotoxic in almost 80%. This toxicity is transient. However, if men are desiring fertility, we can switch to its active metabolite mesalazine, which has not detrimental effects on spermatogenesis. Another anti-inflammatory is colchicine. We all know by experiments that it halts the meiotic or mitotic procedure due to microtubule disruption. So it's another agent that we should think of stopping or switching to other anti-inflammatories before going on to father children. Now we get in more popular drugs like antibiotics. They are very broadly used. There are in vitro data that they show alterations in sperm quality. However, these data in vivo are minimal, and they mainly concern nitrofurantoin, ciprofloxacin, ofloxacin, or sulfamethoxazole, and generally sulfa drugs like sulfasalazine. We have to keep in mind that the illnesses that antibiotics treat often have negative impacts on male reproduction, so it's difficult to realize what is the net effect of the illness and the therapy. And problem that most people that treat male infertility should have in mind is that when we use these drugs as empirical therapy, we should wait that their negative effects wane before we go on to reproduction. And the Urological Association has not even a stable conclusion, so they state that although antibiotic treatment for male accessory gland infections might provide improvement in semen quality, it does not necessarily enhance the probability of conception. A special kind of anti-infectious agents are antifungal drugs. Most known is ketoconazole, which blocks the steroidogenesis and testosterone levels are really decreased. It is this kind of effect is reversible. Higher doses are associated with prolonged blockage. There are no data for semen quality or fertility, but it's prudent to use alternatives such as fluconazole, itraconazole, and amphotericin. Now, what about antivirals and HIV? This is a situation that now has become from lethal a chronic disease, so men desire to father children. Disease itself has profound negative effects on semen. Antiretroviral therapy improves semen quality as well as pregnancy rates. And the best way to assess the effects of antiretrovirals on healthy people are healthy men of seropositive partners on prophylaxis. In such patients, pregnancy and live birth rates are comparable to controls. There is a minimal effect on sperm motility, which might be attributed to the inhibition of sperm mitochondrial DNA replication that nucleoside reverse transcriptase inhibitors may produce. And to finalize, we have the antineoplastic agents. This is also another group of patients who are now survivors, and they demand fertility. Cancer itself may affect male fertility, as well as all the interventions that we do. In many of them, almost 25% of them, persistent azoospermia or severe oligozoospermia may result. The gonadotoxic effects of therapy depend on the initial semen quality, on the delivery method of the therapy, the cumulative dose, and the target that this therapy have on proliferating cells and exactly at the spermatogenic cycle. Combination treatment with radiotherapy and chemotherapy will induce more gonadotoxicity than either modality alone. Regarding radiotherapy, doses more than 1 gray may produce permanent azoospermia. However, this is not the case with lower doses. It targets proliferated spermatogonia. Fractionated radiation is more harmful than 1 dose. Shielding may offer some prophylaxis, but scattered radiation is still harmful. Leydig cells are more resistant, so we don't often see hypogonadism. And irradiation increases DFI, so it causes problem many years after its application. Regarding chemotherapy, again, alkylating agents are the most serious problem for men who desire paternity. So we should offer to such patients cytoprotective strategies to minimize the side effects, although I think that the most realistic option is sperm cryopreservation prior to therapy. And to finish, what about much popular drugs like antihypertensive? The problem they do is mainly sexual dysfunction. A1 inhibitors, they produce ejaculatory dysfunction. B1 blockers, they cause erectile dysfunction. So a nice option is to change them with cardioselective B blockers like nebivolol or sartans. Regarding calcium channel blockers, there is a worry that they may affect sperm fertilizing capacity. However, this has not been proven in vivo. And what about retinoids? They are teratogenic. They don't cause male infertility, so be careful. We have to take precautions, And even if the man starts this drug while his spouse is pregnant, he should use safe sex procedures because this can be detected in semen too. And to finish, there is a surprise because there is a study about paracetamol which has been shown to cause sperm abnormalities, including DNA fragmentation, and increased time to pregnancy. Of course, this was reversible, but it may affect many, many people. To sum up, the levels of evidence for the effects of drugs on male infertility are still insufficient, with certain exceptions. There are confounding factors to assess the male infertility damage that the drugs produce. The effects on spermatogenesis and sperm parameters are generally reversible. If it is impossible to stop a therapy, switch to a less toxic agent or add antioxidants, they may help. As far as concerning teratogenic or mutagenic molecules, safe sex is the answer, and cryopreservation or cytoprotective strategies ought to be sought to minimize the risk of permanent sterility with agents that are known to cause such problems. Thank you very much for your attention.